early osteoarthritis will manifest with an intermittent pain in the joints, stiffness, mild swelling and joint blocking. And without intervention, they will lead to progressive osteoarthritis, which can be painful and lead to need of joint replacement. Now, important thing in this scenario, that is the patient in which you have these acute onset mechanical symptoms, is to do an early MRI, because MRI will be a main factor which will be able to diagnose the problem. So, early diagnosis is very, very important. So, you can start, you can go with other lifestyle modifications, other therapies, but I would be focusing my role of arthroscopy and osteotomy in this particular subset. So the most important internal derangement of the knee which you will be coming across are meniscus injuries, ligament injuries, spontaneous osteonecrosis of the knee joint, that is called as a SPONK, and now we have realized that this is most commonly due to a root injury sequelae. You can have osteochondritis dissecans, chondromalacia of patella, and then you can have rare things like patellofemoral pain syndromes, PVNS, etc. Now, essential things, as I am repeatedly emphasizing, is painful recurrent locking, pseudoparalysis of the knee, inability to bend the knee, inability to extend the knee, sudden loss of motion, sudden loss of function of the knee, and occasionally you may have patient complaining of something which is moving inside the knee. Physical examination, you have to do inspection, palpation, range of motion, and some special tests. But by and large, the gold standard for soft tissue evaluation is an MRI scan, and you should have an art of doing MRI early, because MRI will pick up most of these pathologies with a very good sensitivity and specificity. X-rays will only diagnose the bony problem, whereas the MRI will diagnose both the bony and soft tissue problems. So we all know that loose bodies can cause locking, but loose bodies occasionally can be seen in X-ray, and occasionally there are non-calcified loose bodies which may not be seen in the X-ray. So MRI will be a very good investigation for that. Occasionally we do CT and ultrasound, but the role is very limited. Now MRI, as I told you, gives a very detailed soft tissue imaging. It is a non-invasive, without radiation exposure. It can detect complex injuries. It can detect soft tissue loose bodies, and it will help us into a clinical decision making. Now, arthroscopic interventions, when are they helpful? The most important indication will be a meniscus issue, and nowadays we are not recommending meniscectomies. So previously, with a meniscus tear with a locked fragment, the standard surgery which was performed was a meniscus trimming or meniscus removal, which is called as meniscectomy. Nowadays we have went away from that, and we are more focusing on meniscus repair, and I'll come on to that. Then you can do ligament reconstructions. If there is a PVNS or a soft tissue loose body, you can remove it. You can do chondroplasty, mosaicplasty for lesions, for localized lesions. You can do stem cell procedure, which is called as an autologous chondrocyte implantation, and there is an episurge and loose body removal. Now, the most common IDK that you will see in your practice will be a meniscus injury. Basically, meniscus is a cushion or a shock absorber of the knee, and whenever the knee is loaded, the cushion takes the weight of the knee. So there is a protection of articular cartilage, and whenever the meniscus is damaged, you will start a progressive osteoarthritis. So the most common, so you have two meniscus, medial and lateral meniscus, and the most common IDK that you will see will be meniscus injuries or tear of meniscus. Now, there is a one recent concept which has built up, and that is called as a meniscus root tear. Now, meniscus is attached to tibia with a root, just like a plant is attached to soil with a root. So, this is one of the main important pathogenic factors which has been determined to be the causative agent of early fast progress of osteoarthritis. So, what happens if the root is torn? The meniscus is displaced from its place and it goes onto the medial side. So, this is the classification of Laprade. And if you leave a meniscus root tear unattended, it will lead to a very rapid progression of osteoarthritis. So if you leave a root tear, meniscus complete root tear unattended, it will lead to a very fast progression of osteoarthritis. In 1 or 2 or 3 years, the patient will need a total knee replacement or a partial knee replacement surgery. So this is a very high risk predictor of a rapid onset of osteoarthritis. If you see nowadays, many patients are coming in 30s and 40s with full-blown arthritis, and this is one of the very important causative factor. Previously this disease was not recognized, now it is recognized and now it is to be fixed. So there are two techniques of fixation, a transtibial technique and a root fix technique. So I'll be just focusing on this particular technique. This is called as a root fix technique. So this, what we do is, because the meniscus is torn from the tibia, we put an anchor on the tibia and we repair the meniscus onto the tibia with the help of this device, and this is called as a root fix device. So this is a patented device and we fix it onto its place. So this is how it works. This is an animation. So when the root is avulsed from its attachment, we put an anchor in a retrograde fashion. So where the root is torn, we put an anchor in a retrograde fashion. So these are the two simultaneous video. One is animated video, one is an actual video. So the drill goes in. The drill goes in, and over that we put a needle. Over that needle we put a wire, and over that wire we put an anchor. So these are three steps. Once the anchor is inserted into its place, then we pass sutures, sequentially sutures. So this is the way that we pull the anchor into its position. So now you can see in the animated video, the anchor is coming into the place. The anchor locks into its place, and then there are suture threads which are coming from the anchor, and with these suture threads we can repair the meniscus which is torn. So the meniscus root, where the meniscus is torn, we can attach it back to its original place. So this is called as a root fix technology. This is a very recent advancement which prevents the fast or a rapid progression of osteoarthritis if it is performed at the right time. So this is the final picture. If you see in the other video, you can see that the meniscus is repaired, and in the animated video you can see the same thing. Now in the MRI scan you need to see two signs. There is a ghost sign in which you will not be able to see the meniscus there, and there is an extrusion. So the meniscus will extrude medially and it will become non-functional. And the spontaneous osteonecrosis of the knee, sponk lesion, is now it is realized that it is actually a sequelae of a root tear. So if there is a root tear, the meniscus, the condyle will go sort of an osteonecrosis because of the overloading, and that will cause as a sponk lesion. There is another sign in the MRI which is called as a truncation sign. Now just a small case for 40-year-old female presenting like this, early OA, and these kind of pictures, root tear with extrusion. So this is the anchor that we use, we just saw, and this is a small video. So again we see that the joint is starting to degenerate, and there is a root tear, and we just use the anchor into its place in the retrograde fashion. So you can see that the anchor is now going in. This is an all suture, non-metallic, non-plastic anchor. It goes in, and then we take sutures into the meniscus and repair it back onto its position. So the meniscus repair is into its place, and the meniscus which is non-functional becomes a functional meniscus, and it's loading more of the joint forces. So the progression of the osteoarthritis in these cases will be slowed down, and the need of joint replacement will be delayed. And bad patterns you can address with this. So if you see the pre-op and post-op, you can see that the ghost sign, truncation sign is reduced, the meniscus extrusion is reduced, and we are actually able to reduce the progression of the osteoarthritis. So you can see the pre and post-op MRIs. Here we are seeing ghost sign, and here you can see the meniscus, and then in the tibia, if you see, you can see small anchors into its place. So this is the anchor on the tibia in the post-op images, if you can see. So again, this is sponk lesion. You can have it with a root tear. And the second thing which is very common nowadays is post-corona. So post-corona, you can have an avian or bone infarct in the knee. That is also we are seeing very common. This is called as a smoke up the chimney appearance. And specifically after corona, we are seeing a lot of knee infarcts, just like we see the avian of the hip. We are seeing the avian in the knee as well. So this is again a common thing. Then we can have ligament injuries, and ligament injuries can be addressed with ligament surgeries like ligament ACL and PCL reconstructions. Loose bodies and OCDs can again be addressed with removal of the fragments and fixation of the fragments. You can have Baker's cyst on the posterior part. This is again a very common cause. You can actually palpate a cyst on the posterior aspect of the knee, and this also you can decompress by an arthroscopic means. And you can in MRI you can see that you will be seeing a classical picture of a cyst on the posterior aspect of the knee, and these kind of cysts can be addressed and removed arthroscopically. And then you can have lesion on the patella, chondromalacia. This will cause main problem when you are coming upstairs or downstairs. So typically the patients will have problems in climbing up the stairs and down the stairs. And these again, if they are symptomatic and localized, can be treated with chondroplasty surgeries. And nowadays there is one new technique which is called as an Episurf technique. Now my talks are basically the early diagnosis. It is very, very crucial. Get an habit of doing an early MRIs of those patients who are presenting to you with mechanical symptoms like locking, popping, sudden increase in pain, effusion, instability. So try to do early MRIs in those patients. A comprehensive management is important. Arthroscopy has evolved a lot from the meniscectomies which were done in the past. By today, now we are not recommending meniscectomies, and we are able to repair meniscus in most of the cases, and that will restore the biomechanics of the knee. So root tear treatment, as I emphasize, it's a very common thing, very common missed diagnosis. So if you have an MRI diagnosis of a complete root tear, better to do a root repair with like a root fix device. Meniscus injury, again I emphasize, you need to repair them, not to do a meniscectomy, because if you do a meniscectomy, it will not prolong the life of the knee. It will actually, the progression will be the same. If you do a meniscus repair, you can actually delay the progression and delay the osteoarthritis per se. Ligament injuries like ACL and PCL can be treated with reconstruction surgeries. And if you have an alignment problem with an early OA, HTO can do wonders, and this can be combined with a root tears, root repairs, ligament injuries like a ligament repair, ligament reconstruction surgeries like that. Thanks a lot.
Thank you, Dr. Babu. We will take questions at the end of session. For the next talk, I invite Dr. Vivek Shetty.